This is Michael Altos recording part 3 of the Hemostasis section of Barish chapter 16. Let's talk now about the drugs that affect platelet function. First, we should talk about the cyclooxygenase inhibitors. This would be aspirin and other nonsteroidal anti-inflammatory medications. Remember that COX-1 is the enzyme that initiates formation of thromboxane, and this is important. This is the enzyme that's important for platelet aggregation. So aspirin is a non-competitive, irreversible COX inhibitor. It inhibits both COX-1 and COX-2. The other NSAIDs like ibuprofen or naproxen are competitive and reversible inhibitors of the COX enzyme. But something that's completely COX-2 specific actually does not get involved with this process here, with this platelet aggregation. In fact, the really specific COX-2 inhibitors were associated with prothrombotic state, and that's why some of the drugs like Vioxx and Bextra were actually taken off the market, because of their association with coronary events. There are also phosphodiesterase inhibitors like dipyridamole, caffeine, or theophylline, and by increasing cyclic AMP production, these drugs inhibit platelet aggregation. We see nowadays some more modern drugs like the ADP receptor antagonists, and these include clopidogrel, which is Plavix, prasugrel, which is Effient, and ticlopidine, which is Ticlid. These are drugs that we see being given a lot by cardiologists and perhaps neurologists. These drugs prevent the expression of the glycoprotein 2B3A on the surface of the platelet. People give these drugs to prevent myocardial infarction or stroke, and most commonly to prevent thrombosis of a cardiac stent that has been placed. These drugs are irreversible antagonists, and what's more, they're often given in combination with another antiplatelet drug like aspirin, and these patients will really have very compromised platelet function as a result. One thing you should be aware of, not just for your clinical practice but for board exams, is that Plavix, clopidogrel, is a prodrug, and when we give it to the patients, they metabolize it into the active drug, and there is a percentage of our patients who have a polymorphism that makes them unable to activate the drug, and there is a test which you can use to determine whether patients can take Plavix or not. And this has become more standard now in these days, that when patients are started on Plavix, afterwards they're followed up with a test to see if they are able to metabolize the Plavix into the active drug. There are other glycoprotein 2B3A receptor antagonists. These you may have heard of, like Riapro or Aggrastat or Integralin. These are usually IV drugs. They're given for acute coronary syndrome. Their effect can be monitored with ACT actually. And they're usually very reversible, so their half-lives might be anywhere from 2 to 12 hours, although the clinical effects can persist for longer. And these drugs carry some risk of thrombocytopenia as well. Take a moment to see if you have any questions about the material so far, and then we will continue on. Warfarin, or Coumadin, is a much older drug. It's still, for many patients, the first-line agent in treating the hypercoagulable disorders that we discussed before. Venous thromboembolus, stroke prophylaxis in patients with atrial fibrillation, mechanical heart valves. And the way it works is by competing with vitamin K. And by doing that, it inhibits both the synthesis and the function of the vitamin K dependent factors. And you should know these factors. They are 2, 7, 9, and 10, as well as proteins C and S. Remember, we discussed before that proteins C and S are the first ones to be inhibited. So paradoxically, when you give someone Coumadin, the first thing that happens is they become hypercoagulable. And that's why we usually start patients on heparin first, And once they're therapeutic on heparin, then we start the Coumadin, and then we can stop the heparin after a day or so. Patients can actually change the clinical effect of Coumadin just by changing how much vitamin K they take in. And a significant change in either direction of vitamin K can have a significant clinical impact in patients who are already taking Coumadin. These patients have to have their INR monitored. Usually the goal is to have an INR of about 2 to 3. The onset of action of Coumadin is fairly long. It's about 2 to 4 days, and its half-life can be up to 40 hours. And so they'll need to be rechecked regularly to see which dose works to get them to the target INR. To make things more complicated, warfarin is metabolized by a cytochrome P450 family that interacts with many other drugs, including antibiotics and barbiturates, phenytoin, PPIs, and patients can have genetic polymorphisms. So really, every patient on Coumadin needs to go to Coumadin clinic and have their blood drawn regularly at first to ensure that they're getting the proper dose in order to be in the target INR range. Unfortunately, patients on Coumadin are at increased risk of developing bleeding complications. And we see this all the time, especially patients with subdural hemorrhages and other bleeding. When this happens, we can reverse it with vitamin K, although that's relatively slow. We can give FFP, which needs to be given at a dose of about 15 milligrams per kilogram. That's a lot of fluid. Or nowadays, we're able to use the PCCs, the prothrombin complex concentrates. People have used recombinant factor 7A to reverse Coumadin, and this seems to be less popular nowadays based on the current evidence. But we do need to remember that the best PCCs are the 4-factor PCCs that contain factor 7. You should know that Coumadin is teratogenic. It can cause a number of birth defects, and for that reason we don't give it to pregnant patients or patients who may be at some risk of becoming pregnant. Another common anticoagulant that we see in clinical practice is heparin. And regular old heparin, which we call unfractionated heparin, works by binding to antithrombin 3 and potentiating it. It makes antithrombin 3 more active, and the antithrombin 3 goes and inhibits thrombin. It also inhibits a number of other factors. Heparin is usually used in the inpatient setting because it's given IV or IM, and it works very rapidly to initiate and maintain anticoagulation. It can be used for acute coronary syndrome or pulmonary embolism, cardiopulmonary bypass, vascular surgery. Because it's charged, it does not cross the placenta, and so it's a very ideal drug for using in the inpatient setting. Now, how do we measure whether the heparin has achieved its effect? Well, it's hard to measure heparin levels, and so usually we measure heparin activity. Classically, that was done with a PTT, and you would try to keep the PTT at about 1.5 to 2.5 times the patient's baseline level. We mentioned before there's an ACT, an activated clotting time, activated coagulation time, and this is pretty easy to use. It's pretty reliable for heparin, and basically you have a little tube or a little slide, and you mix the blood with some sort of activation substance. Often it's earth or a silicate of some kind, and then you measure how long it takes until clot is formed. Usually the way this is done clinically is you give the heparin and then you wait 3 minutes for the heparin to circulate, and then you draw your blood sample and check the ACT. For a vascular procedure, you would want an ACT about double the baseline, so we always check a baseline before we give heparin. Now, in our hospital and many others, there's actually a heparin activity assay. And this is the most reliable, certainly for patients who are on the floors who can't necessarily have an ACT drawn. And so you want to target to be somewhere between 0.3 to 0.7 units per milliliter. How do we dose heparin? Well, the idea of heparin is that a unit of heparin is the amount of heparin that would prevent a milliliter of blood from a cat or from a sheep from clotting for 1 hour. So that's a unit, practically, if we're loading somebody up with heparin because they have a clot, you give them usually a bolus of 80 units per kilogram and then start them on an infusion at 18 units per hour. In our anesthesia world, more commonly we'll see the vascular surgeons asking for heparin. Usually they'll ask for about 5,000 units. They're trying to get the ACT at about 2 times the baseline. On cardiopulmonary bypass, the dose of heparin is about 300 to 350 units per kilogram. So we're talking tens of thousands of units. And we're trying to get an ACT of about 300 to 480 seconds in order to go on cardiopulmonary bypass. But it can be very challenging to dose heparin because the dose-response relationships are nonlinear. There's an awful lot of protein binding. And the elimination half-life actually changes based on the dose. So we do need to use our ACT or some other monitor to make sure we've given the proper dose of the heparin. Heparin can be reversed by a drug called protamine. Heparin is an acid, and protamine is a strong base that can neutralize the acid. Protamine is derived from salmon sperm. The dose of protamine is 1 milligram per 100 units of heparin that is believed to be circulating at the present time. So if a patient's on bypass, that's usually maintained at a pretty constant level. If it's a non-bypass case where you're the only one giving the heparin, a rough calculation needs to be made about how much heparin you expect is still in the circulation since the last time you gave it, and then protamine is dosed accordingly. Now, protamine itself is not a procoagulant medication. Protamine does not promote the formation of clot. In fact, if you just give protamine in the absence of heparin, it can have an anticoagulant effect. So protamine should only be given when you honestly believe that heparin is the cause of the bleeding that is occurring. There are 3 very important side effects you must know about protamine. The first is hypotension, and for that reason we always give protamine slowly, especially in the heart room, where we give a very large dose of protamine. It's given over several minutes' time. The second risk is pulmonary hypertension. And the third is that patients can develop allergic reaction to protamine. One of the most common causes of this is that the P in NPH insulin stands for protamine. So patients can become sensitized to protamine through exposure to NPH insulin, and then they get protamine in the heart room, and they have a full-fledged anaphylactic reaction. Patients can become resistant to heparin if they have an antithrombin 3 deficiency, or perhaps if they have a consumptive coagulopathy where they don't have any more antithrombin 3. Patients who have been through a long heart surgery or multiple episodes of bypass. So paradoxically, we need to treat these patients with FFP. Even though the patient, you're trying to thin their blood, you're trying to make them more coagulopathic with heparin, and it's not working. You wouldn't think that FFP is the solution, but actually the FFP will provide the antithrombin 3 that the patient needs in order for heparin to work. We need to spend a minute and discuss heparin-induced thrombocytopenia and thrombosis, which is called HIT with 1 or 2 T's depending on your convention. Up to 5% of patients who get heparin for more than 5 days are at risk of developing HIT. And there's actually 2 different kinds that are described. There's HIT1, which is just a mild thrombocytopenia. This isn't immune modulated, and it's thought that this probably happens pretty commonly in patients who get exposed to heparin. But HIT2, which is kind of the HIT that everyone's talking about, is an actual immune modulated reaction against platelet factor 4, together with heparin complexes. And this can be confirmed in the lab with a test that's kind of slow. And so practically, when we see patients who are suddenly having a drop in their platelet count or other signs of bleeding or clotting while they're on heparin, if we suspect HIT, we stop all the heparin right away and we switch to some other agent. Often it's a direct thrombin inhibitor like argatroban. Remember, you can't start them on warfarin because of the protein C, protein S inhibition. We don't want them to develop a clot. Usually people who develop HIT don't have spontaneous bleeding, but they may be at increased bleeding during a procedure, and their platelet count will definitely drop if you're checking their platelet counts. Now, in addition to the unfractionated heparin, there's also low molecular weight heparin. The most common would be enoxaparin or Lovenox. This also works by binding antithrombin 3, although Lovenox also has some activity against factor 10A. These low molecular weight heparins don't have a lot of effect on the usual coagulation tests, so you might not see a big difference in their PTT or their ACT. They also are not reliably reversed by protamine. So practically, these patients aren't monitored and aren't reversed. They're just given a standard weight-based dose. Now, you could check a factor 10A level, and in some hospitals that may be possible now. But practically, they're just dosed once or twice a day, and that's how these drugs are typically used. They are renally cleared, so a dose needs to be adjusted in those patients who have renal disease. And you can get HIT with low molecular weight heparins, although it's probably less common than with regular heparin. There are a number of newer agents that have come out and are continuing to come out. There are direct thrombin inhibitors like Pradaxa, Argatroban, Angiomax. There are direct factor 10A inhibitors like Xarelto and Apixaban. A lot of these drugs have short half-lives. They have rapid onset of action. You don't have to monitor the patient's blood levels. They don't interact with dietary changes. You can use them in patients with HIT. And if you need to reverse them, most people recommend using the PCCs. And so you'll be seeing these drugs occurring more and more as alternatives to Coumadin and some of the other drugs. There are also indirect factor 10A inhibitors, the most common one being fondaparinux, which is Arixtra. These drugs mimic the binding site of heparin, and so they bind up to antithrombin 3, and they inhibit factor 10A, but not thrombin. So these drugs have a very low risk of HIT. They're a good alternative for the prophylaxis and the treatment of DVTs and PEs, and again, they are renally excreted. Here I'm just showing you the chart that I put into your notes. This is from the Anesthesia Patient Safety Foundation newsletter from a couple years ago, and it just goes over some of these drugs and some indications, some routes, some half-lives, different metabolisms, monitorings, and antidotes if there are any. This is the kind of thing that it's hard to memorize, and I find myself going to charts like this all the time when I'm confronted with a drug that I don't have a lot of experience with. If you have any questions, take a moment to make note of them, and you can contact me or bring them to class and we can discuss them together there. The last few drugs we'd like to talk about in this section. The first one is recombinant factor 7A. This drug directly activates factor 10 and initiates the thrombin burst. If you go back to the flow chart that we had at the very beginning of the lecture, you can refer to that and see where factor 7 directly activates factor 10. It does this without factor 8 or factor 9. It bypasses them. You do need a little factor 5. You need factor 10, obviously. You need some factor 2. You need some fibrinogen. And at least some platelets. This drug was originally designed for patients with hemophilia because it bypasses factors 8 and 9. Nowadays, where there's recombinant factors 8 and 9, what is the role of factor 7A? Mostly it's become the hemostatic agent of last resort. And it's been used successfully in trauma patients, patients with liver failure, GI bleeds, OB disasters, intracranial hemorrhages, transplantation. It's been used to reverse Coumadin, although it's no longer recommended for that. Some people thought it would be a real magic bullet. And the first question was what dose to use. So we know the hemophilia dose is 90 micrograms per kilogram, but what about your patient who comes in by EMS for a massive trauma? Most people would start with 20 to 40 mics per kilogram if it's not an emergency, and more like 40 to 90 for more urgent situations, with the maximum dose of 200. Its half-life is only 2 hours, so you have to redose often, and the drug costs $1 per microgram. So if you're giving 100 micrograms per kilogram, that's $100 per kilogram. If the patient weighs 100 kilograms, so now you've spent $10,000, and that's just for the first dose. So it's a very expensive drug. Because it's the hemostatic agent of last resort, it's very likely to cause thrombotic complications, strokes, MIs, pulmonary emboli, clotted devices, and so it really probably should not be used, unless absolutely necessary, in patients who are at risk for a clot, patients with coronary disease, history of stroke, DIC, patients who have a device. Now we have an alternative called prothrombin complex concentrates, or PCCs. This is also FDA approved for treatment of hemophilia, and it's starting to replace factor 7A as the drug of choice for emergently reversing vitamin K agonists like warfarin, managing critical bleeding during surgeries or traumas or liver failures. There seem to be a lot less thrombotic complications when you compare it to factor 7A. Also less risk of infection compared to FFP, as well as the issue of fluid overload. Usually PCCs contain factors 2, 7, 9, and 10, and some kind of anticoagulant. There is a 3-factor composition in the US, which is much less effective, because that factor 7 is pretty useful. Notice that the factors 2 and 10 have much longer half-lives, in the 30 to 60 hour range, so you don't really need to redose this every 2 hours like you do with the factor 7A. And a lot of people will check a tag before they redose this drug. Nevertheless, if patients have DIC or other high risk of thrombosis, you'd probably want to at least think twice before you administer PCCs. Now we've talked about DDAVP, desmopressin. What is that? That's a substance that actually causes release of factor 8 from von Willebrand's factor. It also causes release of TPA. Desmopressin experiences tachyphylaxis, which means that subsequent doses have less effect than the initial dose. We said before that DDAVP is the treatment of choice in all kinds of von Willebrand's disease except 2B. People will also use DDAVP in patients who have mild hemophilia and in conditions where platelet function has been compromised, so uremia, COX inhibition, dextran, and Plavix. Now this DDAVP stands for arginine vasopressin. But the activity is really only at the V2 vasopressin receptors, which means that you don't get any of the vasoconstriction that you see with regular vasopressin. But you do see some of the antidiuretic effect. And usually the drug lasts for about 6 to 8 hours. The last thing for us to discuss are the AntiFibrolytic drugs. These drugs are used to decrease bleeding both intra and post-operatively, and they've been used in almost every kind of surgery that can bleed, whether it's cardiac or liver or orthopedic or OB, cranial, craniofacial. What these drugs do is they form a complex with plasminogen and they prevent it from activating into plasmin. So basically these are drugs that prevent fibrinolysis and stabilize clot. And they do have some risk of thrombosis as well. The one that you're going to see most often is Amicar, which is epsilon aminocaproic acid, or tranexamic acid. These drugs are lysine analogs. They're cheap. They, like we said, prevent plasmin from being converted in. They prevent plasminogen from being converted into plasmin. They also inactivate plasmin. And there is some risk of thrombosis with these drugs, so we avoid it usually in patients who have a history of a clot or coronary vascular disease or any sort of stent. It's also contraindicated in patients who have a history of a seizure or microcirculatory problems in the retina. Down here I put aprotanin. Aprotanin is basically off the market nowadays, but it may still show up on some exams. And aprotanin was a serine protease inhibitor, which was wonderful for preventing bleeding during heart surgery. It was taken off the market because there was some question of increased risk of graft occlusion, as well as questions about MI and renal failure. Probably the most interesting thing about aprotanin before that was that there was some risk of having an allergic response, especially in patients who had previously been exposed during a prior heart surgery. That's it for this section. Please let me know if you have any questions, and we'll look forward to seeing you in class.